Hello and welcome to the Surgical Academy's talk. This is the second of our on-call survival series. Today we have Miss Eunsol Kim, who is an ST4 plastic surgery registrar working at St. George's, and she's going to be discussing the common conditions in plastic surgery that may be encountered by junior doctors at F1, F2, or even SHO level. Over to you.
Thanks. Hi, everybody. Thanks for the introduction. Can I just have, just raise your hands if you're a medical student? And anybody postgrad? Everybody's postgrad then. We don't have any undergrads.
I think everyone from our registration is postgrad, yeah.
Okay, fine. So let me share my screen. So my topic I found quite tricky because plastic surgery is so vast, and I didn't want to overlap with next week's talk on the emergencies. So I've tried to keep it as relevant and not overlapping as possible. So there are lots of subspecialties in plastic surgery. I think there's 14 or so, and I don't think this is exhaustive at all. But hand surgery, skin cancer, and burns are the bread and butter of plastic surgery. And then you might know that we also do breast reconstruction, and aesthetics, of course, but you might notice lots of things that you haven't seen before, like sarcoma. What is that? Facial reanimation, abdominal wall reconstruction, and lots of pediatric stuff. So congenital ears, hands, extra feet, toes, fused fingers, all of these things. I won't be going through all of these. I will just go through the common things that you might expect to see anywhere between your foundation years and your core training years. So skin cancer, very common, bread and butter of plastic surgery. As you may know, that these are the 3 or 4 most common plastic surgery conditions you can have, most common skin cancers you can have. This is the basal cell carcinoma. This is superficial spreading just by looking at it because it's nice and flat. If you look under the dermatoscope, you'll see that there are arborizing blood vessels. It might have a bit of a rolled edge. And moving on to squamous cell carcinomas, you can get squamous cell carcinoma anywhere in the body. But on the skin, usually it is crusty, doesn't heal. It might have an elevated look with a central keratin plug, which is a keratoacanthoma, which can become a squamous cell carcinoma, and of course melanoma. All of these have excision guidelines. These are really important for you to know. They are available on the British Association of Dermatologists website. They are usually divided into low risk and high risk lesions. So basal cell carcinoma, if it is a low risk, which means it's small and it's not tethered to underlying structures, then you just do a 5mm margin, which would give you a 95% clearance rate. And if it is a large, quite advanced basal cell carcinoma or an aggressive infiltrative type BCC, then you might want to take a centimeter margin. Squames, 4mm for low risk, 6mm for high risk. Melanoma, you always do an excision biopsy, so you have to remove the mole in its entirety with a 2mm margin with a cuff of fat. And then if it turns out to be a melanoma, then you will take a wider excision of that scar based on the thickness of the melanoma, which is called the Breslow thickness. And the reason for that is to mop up any cancer cells that may have started to spread from the central melanoma. And it's just to try to mop up those cells and reduce local recurrence. Merkel's is pretty rare, but often it looks this sort of strawberry-like lesion, and they get referred quite late, and Merkel's can metastasize to lymph nodes. Next is hand surgery. You can get elective and trauma hand surgery. The common elective procedures are trigger fingers, carpal tunnel, and Dupuytren's disease. There are obviously more complicated things in an elective fashion that are done to treat the complications of trauma often, which can be, releasing a joint after an injury and it's become tight, or you've lost a tendon and you want to do a tendon transfer and reconstruct it. And then you have your acute trauma. So anything in the hand, flexor tendon, extensor tendon, digital nerve, fractures that may require fixing are within this boundary. I first wanted to talk you through these vocabulary because this is the sort of words we use all the time. And if you don't know what these mean, or if you don't know how to use these words, you won't be able to communicate with a plastic surgeon very well. So volar is the palm side, dorsal is the back side, proximal is closest to the heart, and distal is furthest from the heart. So if you think about the soft tissues of the hand, you have the flexor digitorum superficialis going to the PIPJ, and the FDP, flexor digitorum profundus, going to the distal phalanx. And FDS bends this, and your FDP will bend your DIPJ. And so if you have a knife laceration, you can cut through either or both of the tendons, and you won't be able to bend your finger. Similarly, on the extensor side, the extensor is not like a flexor. Flexors are like a rope that attaches to the muscle, which is arising from your medial epicondyle. And so if you cut it, the tendon can retract like an elastic band. Whereas an extensor is more flat and diffuse, and it is a mechanism. So it surrounds the top of the finger. So even if you cut it, it doesn't retract like a flexor tendon. It usually stays where it is. There is just a cut. Which is why if you ever see a flexor tendon injury in A&E, you should wash it out under local anesthetic and put them in a volar slab. So a POP, plaster of Paris, in this position. This is a position of safety for hands, so that the tendon doesn't retract any further. And then digital nerve. So in each of our fingers, we have the two neurovascular bundles on either side of the finger, and they are on the volar surface, not the dorsal. So common injuries are avocado injuries. So you're trying to take the seed out with the knife and then it slips and you jab, one or the other side of the hand, and you have immediate onset numbness on that side of the finger. And so digital nerve repairs are also very common procedures we have in plastic surgery. This is a flexor tendon I repaired the other day. So it's nice and springy, it's all intact now. And this is just to show that the cascade of the fingers has returned, because preoperatively, the finger was sort of out like this because there's no flexor bringing the fingers down. So, if before the operation it was like this, by the time you've repaired it, the finger will come back into the normal cascade. There we go. And then fractures. So it's really important for you to understand the terminology again. So this is the metacarpals here, which are in your palms. And then you have your proximal phalanx, which are these bones, distal phalanx, middle phalanx, distal phalanx. And of these, you also want to be able to describe, which part of that bone is fractured. So is it the proximal phalanx mid-shaft transverse fracture, or this is a fifth metacarpal neck fracture. So you want to talk about, is it in the head? Is it at the base? Is it at the shaft? Is it on one of the condyles? Is it intra-articular or not? Is it open or not? Open fractures all need washout under local anesthetic again. And fractures, depending on what they are, needs fixing or not. Usually the indications for fixation is whether it is, if it's unstable fracture. So a transverse fracture like this is inherently unstable. Or if you have an oblique fracture going this way, that's inherently unstable because the fractures can slip. Boxes fractures like these rarely need fixing at all. And we talk about angulation of the fracture. So a volar angulation about 40 degrees is accepted in metacarpal neck head fractures. And just talking about the distal phalanx, you can get a mallet finger. So if you have forced flexion, the insertion of the extensor digitorum communis, EDC, into the distal phalanx can avulse off and you get a mallet finger like this. Alternatively, on the other side, if you have forced extension while you're flexing, so this is called a jersey finger. So in rugby, if you're grabbing onto someone's shirt and the shirt pulls out forcefully, then you can avulse the base of the distal phalanx on the volar side where the FDP inserts, and that can be yanked off. The jersey fingers always need fixing. Mallet fingers may or may not need fixing, depending on what the situation is. Grafts versus flaps. So a graft is when you're taking a shaving of skin. So you always take the epidermis, which is the top layer, and then you take varying degrees of the dermis. You use this machine called a dermatome, and you can adjust the thickness of the graft that you want to take, and then you just go and shave the skin off. And you can use it in areas like this. So it looks super pale because it doesn't have a blood supply. So you have to stick it down nicely and you get neovascularization. So the blood vessels grow up into the graft from the bed of the wound. And this means that you can't have shear force and you can't have a hematoma underneath the graft, otherwise the graft won't take. On the other hand, a flap is a piece of skin, and this can include either the skin, muscle, fat, bone, and you find the, we call it angiosomes, but the paddle of tissue and it's perforating blood vessel that supplies that patch of skin or muscle or whatever it is. And so you take the block of tissue and its blood supply on block to the new area, and you anastomose the artery and vein into the recipient artery and vein so that you have direct inflow and outflow from the new location. And so grafts survive by neovascularization and flaps survive by direct arterial and venous in and outflow. So where do we use free flap applications? So if you remember my first slide, any cancer that we cut out in the body, head and neck, breast, abdominal wall, back, bum, arm, sarcoma, limbs, anywhere anybody creates a hole, we can fill with whatever tissue is required for that piece, that part of the body. And so free flap surgeons are versatile and they can usually work anywhere in the body. This is what you should look out for. This is what you could be called for. A failing flap is not common, but it's something that you need to pick up early. So if you have a problem with the inflow, you're going to have a pale flap. If you have a problem with the outflow, so it's congested because you have blood going in but nowhere for it to get out, then you're going to have a blue flap. So this is a blue-purple flap, and it means that this has a venous problem. And if you see me doing a cap refill, it is now fixed. So you have a bit of cap refill there. It's almost normal, really. That's probably a normal cap refill. But the remaining skin has fixed staining, which means it has been compromised for quite a while. You really need to be catching these failing flaps much earlier on when you have sort of that red hyperemic congested look before it gets fixed purple like that. And so if a nurse calls you to the ward because they're worried about a flap, you need to go and have a look, check the cap refill. And it's not like this. You need to press down for 5 seconds and then read the cap refill. Early signs of venous congestion is a brisk cap refill. So if the cap refill is like less than 1 second, you might want to discuss with a senior. And then your basic stuff. So if the patient is dehydrated, you may have a volume problem. So you might have an inflow problem. So you need to make sure that they are well topped up, that their pain is well controlled, because pain increases your fight and flight response hormones. So that can cause vasoconstriction and therefore cause problems with the flap inflow again. Is the dressing too tight? So if the dressing is too tight, that can cause either arterial or venous problem. Or is there a hematoma underneath the flap? So you have an expanding hematoma underneath the flap, and that is causing internal compression on the arteries and veins. I think I'm coming to the end. Another common thing you'll see is complications from aesthetic surgery. I called it the Turkish delight because we have a lot of patients that come to our A&E after having these cosmetic procedures abroad, especially in Turkey. And so this is a breast mastopexy. A pexy means that you're doing an uplift. So you go from a droopy breast to a perky breast. As opposed to a breast augmentation, so you're changing the volume. So you go from a flaccid breast to a fuller breast. And this is an abdominoplasty where you have a tummy tuck, you elevate your whole abdominal pannus, and then you pull the remaining skin down and cut away the excess. And liposuction, as you may know. So what problems can these things cause? Infection. So if you're putting an implant in, that can cause an infection. Seroma is where you get body fluid, building up in new dead space cavities that we have created. And that is very common in abdominoplasty. And that's why we put a drain in under suction. Hematoma, very similar. We do meticulous hemostasis before we close up a patient. And this is to make sure that there is no continuous bleeding that can accumulate in this new space that we have created again. Flap failure, we've already talked about. Graft failure, we've already talked about. And that's it. I hope that was useful. Super quick whistle-stop tour of plastic surgery. Hopefully next session on emergencies will enlighten you a little bit more. But the fundamentals of plastic surgery is underpinned by good anatomical knowledge. So if you ever see a plastic surgery patient in A&E or on the ward and you're clerking them in, think about what could go wrong there, because you know your anatomy. What symptoms do they have? And what problems could have been caused by the procedure? So you need to understand anatomy and what the procedure is, because if you don't know what a mastopexy is, you won't know what complications can potentially arise from that. And so, make sure if you don't know, Google it, YouTube it, make sure you know at least the anatomy before you start talking to a senior about it. I'll take any questions if you have any.
Thank you very much for your teaching. It was very, very interesting. We'll just take a look at the chat to see if anyone has any questions. We have one regarding how, are there any common conditions we could be asked to review with children?
Yes, so children are usually trauma, nail bed injuries, crushed in a door. And so usually when do you take them to theatre? It's when either you have a subungual hematoma of more than 50%, or you can see that you can physically see that the paronychium or the skin, it has been cut and the nail is almost hanging off. If you have a nasty nail bed, it will usually be related with a tuft fracture. Tuft fractures heal very well, so you can just leave them alone. But they do need to go to theatre for the nail plate to be removed and the nail bed to be repaired with something like 6-ovite core repeat. And they heal very well. Nails grow back in about 2 to 3 months. And then if you do have a nail bed injury, you need to make sure that the volar skin bridge is intact. If it's all the way around, then that is an amputated tip, essentially. So make sure if you get a referral about a fingertip injury that they tell you that the pulp is intact, or that they send you a photo of the pulp to make sure you don't actually have a revasc or a composite graft on your hands. And then, forehead laceration, chin laceration, all of these kind of bread and butter things that you can get in children. Those are the common things. You can sometimes get a constriction hair tourniquet on a digit. And if you get that, you just need to get a blue needle and you have to cut wherever the constriction band is to make sure that the hair tourniquet or whatever has been cut completely. Usually children don't have a fully developed pain sensory system. So, it'll be a bit sore, but you can just pin them down and do it. And if you're not sure, you must call your registrar, because if you miss a hair tourniquet, the child can lose the digit. Anything else with children? Accessory digits, extra thumbs, fused fingers, all of these are elective things that you really shouldn't be bothered about. The GP should be referring that to the congenital limb clinic directly. So you shouldn't really have anything to do with that on a day-to-day basis.
Thank you. One more question. Yep. When talking about angulation, is this referring to the distal or proximal fragment?
So I usually talk about the distal fragment based on the proximal. So a volar angulation that fit like a boxer's fracture would be a volar angulated head. But people do talk about like a dorsal angulation. So you're looking at the peak, the tip of the angle of the fracture. So that that metacarpal fracture that I showed you, you could also call that a dorsal peak angulated fracture. So lots of different ways to say it, but in my experience, if you just describe the distal fragment based on the your proximal, because your proximal is always your baseline, then it is probably enough.
Thank you very much. On that note, we're going to say thank you to Eunsol and goodbye. We'll close this webinar and then reopen it so that we can move on to the general surgery teaching session, okay? And letters will be emailed out for portfolio purposes by the end of the day.